physios, I welcome you all to our channel Physio Vidyapeeth. We are back with our next lecture on shoulder complex biomechanics, and here we are going to start coracoacromial arch. Okay, so in this lecture we will study about coracoacromial arch, subacromial space along with the bursa of the glenohumeral joint. So as you all know, my name is Vijay Kumar and let's get started. So coracoacromial arch. Okay, so there are two words. Okay, so this is a arch which is formed by some structures. Okay, so this is the bone, scapula bone. Okay, so this one is the coracoid process and this one is the acromion process, and now I am saying that there is a arch like this. This is an arch. Which arch? Coracoacromial arch. Now you will see that it is made by coracoid process, acromion process, coracoacromial ligament along with the inferior surface of acromioclavicular joint. So which structure make it? It is the coracoid process, acromion process, coracoacromial ligament and the inferior surface of acromioclavicular joint. Okay, so there are total four structures. First one is coracoid, second is acromion, third is the ligament connecting the two, that is coracoacromial ligament. Okay, coracoacromial ligament, and fourth is the inferior surface of acromioclavicular joint. Now these are bones, these two are bones, and ligament is and this joint is also made up of bone, while this is a ligament. So we call it as a osteoligamentous vault. Okay, so what is coracoacromial arch? It is a osteoligamentous vault which is made up of coracoid process, acromion process, coracoacromial ligament and the inferior surface of acromioclavicular joint. Now what are the content that are passing below it? Okay, so this is a arch and there are some sort of structures present below this. Okay, so this is the humerus bone and this is the shoulder joint. Now the arch is like this. Okay, let me just hold it for you. This is the arch. Okay, this is the coracoacromial arch and this is the head of humerus present here. Now the contents which are passing through this arch are head of humerus, definitely it is present below that arch. Next is the supraspinatus tendon, that is a part of rotator cuff muscle. Third is the bicep tendon. And fourth is the bursa. Which bursa? Subacromial SA and the subdeltoid bursa. They are present below the arch. Okay, so the content is very easy to understand. Head of humerus is present below it. Supraspinatus tendon, that is rotator cuff tendons are present. Bicipital tendon is present along with the bursa, that is subacromial and subdeltoid bursa is present. Now important thing is that why this coracoacromial arch is present, or what is the function of this arch. Okay, this is the arch. First function is very easy, that it helps to prevent the superior translation. So if it was like this, head of humerus would easily translate superiorly, but now it is not like that. It is the coracoacromial arch present like this, which will prevent the superior translation of head of humerus. Okay, so under the function you will write it prevent superior translation of head of humerus. Another important function, let me explain. This one is the scapula and this one is head of humerus. Now here the contents are present. Rotator cuff tendon is present, bursa is present and bicipital tendon is present. If I put some load here and let us assume there is no coracoacromial arch. What I am saying, that let us say I removed this arch and placed it here. What is the scenario? The shoulder joint will be like this. Yes, here will be rotator cuff muscle, here will be subacromial and subdeltoid bursa. Also here will be some the tendon of bicep muscle, and I carry some load on my shoulder joint like this. So this load will directly impinge on the structure, which will cause problem, that is it will traumatize the muscle or the bursa, leading to tendinitis or bursitis. Okay, so next function is it prevent integrity of its contents. Okay, its contents. And what are those contents? I have written them above. These are the contents which I am talking about, that is supraspinatus tendon, bicep tendon, also the two bursa are present. So till now what we have studied, that what is subacromial arch, what are the contents of it, and what are the function. So let me just recap this part only. Okay, so what is coracoacromial arch? It is a osteoligamentous vault. Okay, it is made up of coracoid process, acromion process, its ligament along with inferior surface of acromioclavicular joint. What are the content present under it? Definitely head of humerus, bicipital tendon, bicep tendon. Next is the subacromial and subdeltoid bursa, and the rotator cuff muscle tendon is also present. Function: to prevent the superior translation, to prevent the superior translation of head of humerus, and to maintain the integrity of the contents. Now I will make you understand about the bursa, then we will move here. Okay, see, bursa. Okay, bursa. The shoulder joint have two bursa. How many bursas are there? Two bursa. Which? They are subacromial bursa and subdeltoid bursa. Okay, so let me make a diagram for you. This is head of humerus, this is glenoid fossa, and this is the acromion process, and this is the coracoid process. This is the coracoid process. Now if I draw this, what is this? This is coracoacromial ligament. And what is this? This is the deltoid muscle which is present. Now there are two bursa. One is the subdeltoid bursa and other is the subacromial bursa. Though they are written, we can say separately, but functionally they are, we can say, they are connected to each other. Okay, they are connected to each other. So both of them together can be referred as, they are referred together as subacromial bursa. Okay, subacromial bursa. So what is a bursa? There are two bursa in the shoulder joint. Which one? Subacromial and subdeltoid bursa. Okay, let me make the diagram more beautiful. Okay, it is like this. It is like this. This one is the subacromial bursa. This is subdeltoid bursa. Though I have written them separately, but they are, we can say, collectively termed as subacromial bursa. That is, subacromial bursa means I am referring to both acromial, subacromial and subdeltoid bursa. Also, I hope you know the definition of bursa. It is a thin sac that is lined by synovial membrane which contain synovial fluid, and the function of bursa is to, we can say, make the motion very smooth and to reduce the friction. Okay, but due to some causes, if there occur inflammation of bursa, that bursa is called, that is called bursitis. Okay, that condition is called bursitis. B-U-R-S-I-T-I-S. Okay, so whenever there occur inflammation of bursa, it is called bursitis. That inflammation can be due to any sort of trauma to the coracoacromial arch, okay, or due to, we can say, any osteophyte or any other thing due to which the space of the coracoacromial arch get reduces, it will cause bursitis. And the patient of bursitis, this you need to understand, patient of the bursitis will have a special sign called the Dawbarn sign. This means that whenever the patient is in the resting position means when he or she is standing, if we palpate on the lateral and inferior surface of acromion, there will be pain. Okay, that is in this position. If we palpate below and lateral to acromion process, there will be pain, which is called Dobarn sign. Okay, so pain on inferior and lateral surface of acromion process on neutral shoulder. It is called Dobarn sign. This you have to understand. Now I will make you understand about the subacromial space along with its clinical relevance. Okay, this is very important. So this is acromion, this is coracoid, and this is the head of humerus. Okay, this is the lateral view. Okay, and this is the coracoacromial ligament. Now what is this space? This space is called subacromial space or suprahumeral space. It is present below acromion, so called subacromial space, and present above the head of humerus, so called suprahumeral space. Okay, I have written as SAS and SHS. The normal space when the shoulder joint is in the neutral position, that is like this, in the 0 degree, it is 10 mm. It is 10 mm. But as we start to do the abduction, it get reduces to 5 mm. Okay, so what I have explained, this is the acromion process, this is coracoid process, this is coracoacromial ligament. This one is the ligament, this is the head of humerus. So this space, okay, this whole space is called subacromial space or suprahumeral space. And when the position is neutral, this space is big, that is 10 mm. But as we do the elevation, that is abduction or flexion, the space get reduces to 5 mm. Now, what will you think by knowing this thing? That whenever there is increase in the shoulder joint abduction or increase in the shoulder joint elevation, there is a decrease, that is a tremendous decrease. Okay, so there occur half reduction in the space. So you will think that more impingement will occur as the abduction increases. Yes, you will say, sir, here in the neutral position, the subacromial space is 10 mm, and when we do the abduction, it gets reduces to 5 mm. So definitely in the end range, there will be some sort of impingement, but it is not like that. The impingement usually occur in the initial range, and the term initial range means less than 60 degree. So impingement occur less than 60 degree. Why? Let me make you understand. What I have explained, this position have 10 mm space, but as I do abduction or flexion, the space get reduced to 5 mm. But the impingement can occur only in the initial 60 degree. Why? Because after the 60 degree, the supraspinatus tendon get medially rotated, because after 60 degree, the supraspinatus tendon get MR. MR means medially rotated and moves away from the bony prominence. So do not undergo any sort of impingement. Get medially rotated, so move away from acromion process or coracoid process, so there occur no impingement. So these two things are important. Here also in the Dobarn sign, one thing I did not explain, that the pain was only in the resting position, but as we do abduction, here also pain reduce. Why? Because the bursa gets slipped below the acromion process and there occur less impingement. or there occur less pressure on the bursa. So you can relate both the things. Impingement, normally this is 10 mm, but as we do abduction or elevation, that is flexion, space reduces to 5 mm. But with increased abduction, there is no increase in impingement. Why? Because impingement occur in less than 60 degree or near to the 60 degree. Why? Because after 60 degree, there occur medial rotation of supraspinatus tendon, which causes slippage of away from the acromion and the coracoid process, so it do not get impinged. Here in Dawban sign also, pain was at the neutral position, but as we do abduction, the bursa move, we can say, below the acromion process, which have a space, so there occur less pain, because here also pain is more in the neutral or the initial range of motion. Okay, so this is about the subacromial space. Now, another important thing which is related to the clinical relevance. So the thing is that the clinical relevance of the coracoacromial arch, that is the subacromial space, is important due to the integrated function of the supraspinatus muscle and the deltoid muscle. So let me make the head of humerus. This is head of humerus and this is glenoid fossa and scapula. Now, whenever we do shoulder joint abduction, it occurs due to two muscles. First one is the supraspinatus muscle. I will draw it like this. And second one is the deltoid muscle, which is present like this. Out of these two, supraspinatus is the initial abductor. Why? Because whenever we have to do abduction, the supraspinatus muscle will give us the rotatory force. Okay, this rotatory force, that is whenever I do abduction, head of humerus move downward. This rotatory motion is due to supraspinatus. I have written SS below this arrow. And the upward translation is due to the deltoid muscle. So till now what you know is that during abduction two muscle works. First is supraspinatus, second is deltoid. Out of these, supraspinatus have the rotatory component, while the deltoid have the upward translation of head of humerus. Now, out of these two muscles, supraspinatus is very vulnerable to get injured. Why? Because in this neutral position also, there is some sort of activity in supraspinatus muscle, which means supraspinatus muscle is not relaxed even when I am in the resting position. I am like this, closed my eyes. Not even now, the supraspinatus muscle is in rest. So there occur, we can say, weakness in the supraspinatus muscle, and if this supraspinatus muscle will become weak, there will be reduction in the rotatory component. Now I will erase this rotatory component. Why? Because my supraspinatus muscle has become weak, and this weakness is called the complete shutdown of supraspinatus. It is called supraspinatus SS shutdown. What will happen now? Due to extreme work, that is, the supraspinatus muscle is not at rest in the resting position also. So there will be weakness. If there is weakness of supraspinatus, will there be the rotatory component? No, it will not, and that is called supraspinatus shutdown. Now let us see what is the scenario. Now if I will try to do abduction, due to lack of the rotatory component, there will occur only the superior translation. Only the superior translation will occur, which will lead to impingement. So when I am trying to do the abduction, there will be only the there will be only upward translation. Which will cause impingement, called the impingement syndrome or the painful arc syndrome. Pain will be present in 60 to 120 degree. Okay, 60 to 120 degree. This is the clinical part. Okay, clinical part. So did you understand that whenever we are doing abduction, normally supraspinatus will give rotatory component and the deltoid will give upward translation. But the supraspinatus muscle is not at rest even in the complete rest. Okay, so then it is vulnerable to become weak, called the supraspinatus shutdown. Once it gets shut down, there will be only the upward translation of head of humerus left, causing the impingement or the painful arc syndrome, which will produce pain in 60 to 120 degree. Also, due to some other conditions, there will be reduction in the space of the we can say subacromial space or subhumeral space, which can cause impingement, and that causes our bursitis. Okay, bursitis, which can be either subacromial or subdeltoid bursitis. Next, it is due to tendinitis. Either it can be bicipital tendinitis or the supraspinatus tendinitis. Then it can be due to osteophyte, and also it can be due to spur. Also, it can be due to abnormal shape of acromion process and coracoid process. Also, it can be due to thickening of coracoacromial ligament. Okay. Also, it can be due to abnormally enlarged head of humerus. Okay, so these are some other causes. Okay, I have written it here. Bursitis, tendinitis, osteophyte, spur, abnormal shape of the bony prominence, then thickening of coracoacromial ligament and enlargement of head of humerus, which will also cause the impingement. Okay, so with this we are completing the lecture, and till now what we have studied what is coracoacromial arch, how it is made, what are its contents and function. Then about the bursa and its Dobarn sign. Pain will be present in the neutral position when we will palpate on the inferolateral part of acromion process. And when we will do abduction, why pain will reduce? Because the enlarged bursa will slip below the acromion process. Okay, you must know that these bursa are normally very tiny, but when there occur inflammation, they get swelled, okay, and enlarged. Okay, there occur swelling of the bursa. And last is subacromial space, its normal value, and when we do abduction, it get reduced to 5 mm. But till then also, with increased abduction, impingement do not increase. Why? Because when we do abduction, after 60 degree, there occur medial rotation of supraspinatus tendon, which will reduce the chances of impingement, and impingement occur mostly below 60 degree. Okay, and last was the supraspinatus shut down. Okay, so with this we are completing the lecture. In our next lecture, we will study about the range of motion of glenohumeral joint. Till then, you keep on studying. Thank you to one and all.